We're back with another PCBH Corner.
Same clothes, same outfits.
Same clothes, same outfits. 2 weeks apart.
2 weeks apart, though. We came back, right? We came back to the same setting. Yeah.
But when we were in our last episode talking about adopting a primary care identity versus a behavioral health identity, one of the things that I wanted us to talk about was related to a different topic.
Okay.
So, are you ready?
Let's do it.
I know I'm building it up too much.
I like the build up, right?
All right, so through our consulting and through what we've seen out in the landscape of integrated care, one of the questions that comes up a lot or that you see a lot is the behavioral health integration services, so maybe you call it your BHCs, are they providers or are they part of a service or a separate
initiative
program? Yeah, a program, an initiative, or is it the regular service that's already included that you would expect with your PAs, NPs, MDs, and DOs? So then it brings up a lot of questions related to organizational structure, org charts, who reports to who. And I really think that this can be a straightforward corner, maybe, we'll see, with the two of us.
Never.
It's almost never
We'll
straightforward.
go off on our tangents and then won't even be on the same topic.
I wanted, we were saying that as our identity should be as a regular member of the primary care team and from a provider, a behaviorally trained provider.
Yes.
So we are providers and we are on the primary care team.
Yes.
So with that in mind, who do we report through? Where's the line of service for these PCBH programs or BHC programs or whatever it is that folks have named at their organization?
Yeah, I mean, it's really interesting because this just changed for us in the past year or two about who everybody reports to kind of structure-wise. So I think it will be an interesting one, and probably at the beginning saying there might not be a right answer. Maybe we could talk about as always, like the pros and cons of kind of each kind of thing. So let's talk a little bit maybe about our structure within it. So we have obviously the BHCs, the core BHCs report up to you. So anybody that's licensed reports up to Bridge. Anybody that's a trainee reports up to me. And then what we have traditionally had is that then we report up to the CMO. That's what the traditional thing. Now, what's changed this past year or two is that now you and I report directly to the CEO. So there's some pros and cons to that. Now, the other thing is that we don't have a traditional behavioral health or especially behavioral health system. And that's a huge contextual factor because I don't know if I would like a behavioral health department or program reporting straight up to, that's how the reporting structure is, and there's nothing related to the CMO. If there was also a traditional behavioral health, because it would almost be everybody be lumped under one. If that makes sense. Yeah. You can argue with me. That's okay. What people don't see is Bridget's face being like, "Oh no, what are you saying?" So that.
Well, no, it's just we went on a completely different tangent than I had expected.
Which I said is going to be the point.
Well, that's where we are.
So the point, though, real quick, the point of that is that if you have a traditional behavioral health service within your organization, it makes it a very, very intentional conversation that needs to be had. Because let's talk about the pros and cons of this, right? So say you have a traditional behavioral health department in your organization, and you have integrated BHCs, and they're not the same people. They're different people, different functions, different things.
You think that we're disagreeing? We're completely in agreement.
So if we put them all together, there's some good things there because hey, same guild, same profession, all these different things. Like there's a pro to that for sure. And honestly, I think intuitively that probably makes more sense than anything.
Okay.
The problem is that if that reports up, the integrated BHCs, like their team. We actually want it to be more the medical team.
Yes.
We want it to be more the medical providers. We want to have that identity, as we said, as a behaviorally trained provider working in primary care.
Right.
That's what we want the identity to be. If it's in the same grouping as a traditional behavioral health and reporting up through the same person, that identity doesn't naturally kind of happen. So I'll pause there. Where's your mind going right now?
Yeah, I couldn't possibly agree more.
Yeah.
But the biggest thing that we normally see, well, maybe you are right.
Oh. Yes. Thanks for stopping by. Till the next PCBH
Is this
Corner.
leaving on a high note?
Yeah, exactly.
My brain was thinking that most of the time organizations, they choose between going up the CMO route or the COO route. And most of the time when integration happens, it's seen under the COO because it's lumped together with all the other initiatives and all the other programs.
Yes.
And so my argument was going to be, we should absolutely route up through CMOs because they're providers. You brought a different wrench in it, which I'm going to stand by it and I'm going to say it for the second time. I actually think that you're right. There are a lot of agencies that maybe had a traditional behavioral health representative in the org chart. That person may or may not report to the CMO. They might just report to the CEO, or they might also report to the CMO. Or
COO.
Or the COO.
Yeah.
But then everybody on the team, so it'd be including all the traditional therapists, as well as all the new integrated BHCs. They're then reporting to that behavioral health person, then that behavioral health person on up. So where my mind is going is that is everybody's system is different. Everybody's context is different. This is just our opinion on the PCBH Corner officially. I think that that's a bad idea.
To have them together.
And I agree with you that there's some pros because they can have some camaraderie and like, oh, hey, there's somebody else who's an LCSW. I'm an LCSW, or I'm a PsyD. You're a PsyD. But at the end of the day, we want people's identity to be housed in what their role is. So if they're going to be part of the medical team, I want their identity to be related with medical. And so my argument would be, in almost all cases, to go route up through the CMO. So if you go from the BHC to a BHC director to CMO, and so on and so forth, way rather than going directly to a chief behavioral health officer or
oversees a chief behavioral officer that oversees
traditional and integration.
And sorry for interrupting you. Oftentimes chief behavioral health officers, they also oversee care coordination or maybe like social work support. There's a lot of different things that oftentimes that chief behavioral health officer oversees in addition to traditional behavioral health. And I couldn't agree more. Again, grace, love, and compassion. We're just speaking from our opinion. Having the BHCs report through that line of the CMO and the providers is important. Now, let me ask you this. Downside of doing that, any downsides your mind says about reporting up through the medical providers?
Well, I wanted to hold, can you hold that thought?
Yeah, I'll write it down.
So I wanted to go back really quick to in our situation about us reporting directly to the CEO. That is different than everything that we're describing because I'm the director of PCBH. And in our system, we don't have traditional system. And so everything that I'm reporting on is related to primary care.
Yeah.
And so the reason why we decided to have, this org structure this way was just because it made a little bit more sense with me sitting on senior leadership that I can already be the representative. It kind of felt duplicate for okay, there's the director of PCBH who sits on senior leadership. Now, she can speak for all the stuff going on in PCBH, but here, let's route it through the CMO. So it ended up being, the reason why we switched it, from what I can tell, was that it was just, it just was a lack of efficiency. It was duplicate work.
It was redundant.
You knew it. It was redundant.
Yes.
So that's why that we ended up, going that route. But for any other system, unless you have your PCBH director, which is probably going to be more rare, especially for new places, chances that they're going to be sitting on senior leadership is low.
Yeah.
So in those cases, I would have them want to go through whatever medical is going up through versus it being COO or being aligned with traditional services.
Because as we talked about in the last corner, that just, we obviously we're contextual people, right? We like these things, these subtle cues, these stimulus controls that remind you of your team and your purpose. Just reporting up through the CMO the same way, that reminds you of your purpose. That reminds you of you are a behaviorally trained provider.
There it is.
Working in primary care or the healthcare system. Absolutely.
I should have trusted that you could say that. That was really eloquent. So back to your question.
Yeah.
Downsides of this?
Downsides, I think the one big downside could just be that, there's a chance that if you're the director and stuff, you might be reporting up to somebody that doesn't have a lot of experience related to your specialty, to what you've been trained in. So and this is what we've had to do throughout, is like the intentionality of developing relationships and rapport and building trust with each other to make sure that, any kind of decisions or any type of things that we're including the behavioral health team, and we're not making any kind of global decisions that it's like, actually, as a behaviorally trained provider, we can't do it that way. We have to do it another way. So just making sure there's these constant collaborations, because there could be at times that someone, because maybe their background is medical specialty, might be overseeing and making decisions that need to have specific input from that individual that is the director or whatever position making the leadership call.
So you're saying that to really increase that collaboration, have that leadership influence and advocacy, if you're going to route up through CMO or medical, where the chances is going to be another psychologist or LCSW is going to be low.
Yeah, because even I think about sometimes when we get because at CHCW, our home clinic, we're treated as primary care providers, and that's what our CEO kind of says all the time. BHCs are primary care providers, and so we're included in all these provider emails even. And this is like a simple one to kind of describe. And sometimes you get an email sent out. It's like, hey, this is a change to maybe a billing thing, or whatever, and that becomes like, it's like, what does this include the behaviorally trained providers? And so
because as much as we're rowing in the same direction, there are differences.
There are different billing, documentation, all these different requirements. And so the thing that I've always admired about you and it's been so great to see the CHCW leadership respond to this, there's so much collaboration and coordination that now even within those emails, like, hey, this doesn't impact the BHCs. This is,
they're like proactively saying it.
Correct.
Knowing that, hey, everyone's going to read that. Oh, that's cool.
And the other thing that I wanted to touch on that I think is really important, and again, grace, love, and compassion. A lot of times these organization structures are just set up after an initial maybe grant or program. So
that's true.
It makes sense why sometimes it's like, oh, the COO is within the line, because it is a grant, it is a program. Just thinking about how that stimulus control, how that subtly reinforces that it's not part of potentially the greater medical team, the greater primary care team.
And maybe it's aspirational. I feel like if somebody's watching this video, could be like, once again, so Dave and Bridget, you're saying our system isn't this or isn't that. And the truth of the matter is, we don't know your specific system. There could be very good reasons and rationales for why decisions were made and why they're continuing to be made. And it could be aspirational that if the system was started, or the integration was started through an initiative or a grant,
most likely,
or a project, and if it was started that way, if it was housed under the COO, that over time, I think it could be aspirational to try to say, hey, but this is just how we do services in general, and this is how we provide these clinical services. And so it goes under more of the clinical services. I know some places are doing like chief clinical officers, and kind of moving away from it being a chief medical officer versus a chief behavioral health officer, kind of having a chief clinical. So there's a lot of other folks in other organizations that are doing innovative things. And once again, if you're watching this and you're like, well, the reason why we did it was X, Y, and Z, even after we were the program. So Dave and Bridge, this is never going to be aspirational for us. My thing goes down to the truth criterion, which is,
if it works, it works.
Ooh!
If it works, it works. Yeah.
Yeah, if it works, it works. If you're getting the results, if your team is aligned and rowing, and you're part of that high quality primary care, if it ain't broke, don't try and fix it.
Correct. If it works, it works.
But if you are starting up a system, or you're trying to advocate, or you're running into these things where you're just like, this doesn't make sense why I don't have a voice, or this seat at the table, or, I have this team of 5 BHCs, but instead of them thinking about their medical team being their team, they're constantly aligning with this other service, which isn't wrong and isn't bad, but it's just not necessarily like what we do on a daily basis. If you're running into those, that would be a good time to stop, think about your organizational structure.
I love it. Last thing I'll say about this, the other thing that I've really appreciated about you, what happens whenever there's like a behavioral health like conversation or initiative that comes up, and I'm trying to think about, like, say it was like, hey, we're trying to look at PHQ-9 screening protocols. What is your response?
My response is, well, I look and see if it's something that is just required of primary care in general.
Yeah.
So just because I have expertise related to depression, I should have some type of input, but really the ownership is on the overall organization executing it. Because whether or not we were integrated onto that team, they're going to still need the PHQ2 and PHQ9.
And I think that's another thing to even think about as we think, subtleties and just different, is that any time there's these like initiatives or different programs and stuff, I love how you said it. Not to say that you're not going to give input. Just like any leader would give input in anything, it's not owned. Because if it's owned, you're separate.
See, this could be a whole other PCBH corner, but I am glad that you mentioned that just because your background involves that, you have to think about your overall structure in the organization, because you can get pulled in a billion different directions when really you're probably there to lead the integrated behavioral health team, to make sure that you're hiring the right people, making sure that you're onboarding people, making sure that they have competency to be able to do the job. That's what you're there for. Just because you have some expertise in one area doesn't now become, now I'm in charge of all the PHQ2s and PHQ9s in the organization. That is an organizational ownership. So that's actually a very good point, and you got another thing to be aware of as you're in leadership.
Absolutely, absolutely. Well, as always, thanks for stopping by, and you heard it here first. I was right.
Twice.
How about that? All right, as always, thanks for stopping by.